Hey, I'm Dr. Ariana Demers. I'm an orthopedic sports medicine surgeon, and I have successfully integrated orthobiologics into my busy practice so that I can provide a continuum of care and treat patients who are in the gap. The gap is this gray area in orthopedics where standard conservative treatments have not been effective, but surgery may not be warranted. And we usually tell our patients, come back when it's worse. What? These are your patients coming to you for help. Orthobiologics is that solution that can fill the gap and help you treat your patients who are in your office looking to you for help. Orthobiologics can also be an excellent treatment for frustrating problems without good surgical outcomes. This podcast will help you create the orthobiologics business that will make you love your job again. We will focus on the value of orthobiologics, patient selection, how to talk to your patients about money, office setup, and other logistics. If this is something you've always wanted but don't know where to start, join me in the Business of Orthobiologics podcast. Hi, welcome to data collection. Here's what we'll cover. So this is how we know how to take care of our patients and what treatments to use. We'll talk about what data we should be collecting, the MEBO criteria, a primer on cell counting. We'll talk about whether you should get an automatic hemocytometer, a little bit about leukocyte-rich versus leukocyte-poor, and then what about the monocytes? We'll talk about dose calculation and then touch on patient-reported outcomes in registry data. So this is how we know. Data collection in orthobiologic treatments is crucial for several reasons, including assessing treatment efficacy, ensuring patient safety, advancing our scientific knowledge, improving patient outcomes. This data encompasses various aspects, including cellular content, as well as patient-reported outcomes, or PROs. So, data collection allows for treatment efficacy assessment, patient safety and adverse event monitoring, scientific advancement, customized treatment plans, regulatory compliance, as well as quality control and patient engagement and informed decision-making. So a little bit about treatment efficacy assessment. We want to go ahead and look at our cellular content and quantify the cellular composition, including platelets, leukocytes, and red blood cell contamination, as well as any concentration calculations. This allows clinicians and researchers to evaluate the treatment's potential effectiveness and differentiate whether different cell types can have varying effects on the tissue, healing, and regeneration. Talking about clinical outcomes, collecting data on patient-reported outcomes such as pain reduction and functional improvement over time will help determine whether the treatment that you're using with the cellular content you've recorded is achieving its intended therapeutic goals. Additionally, patient safety and adverse events. When we look at monitoring the cellular content of the orthobiologic preparations, such as leukocyte-rich or leukocyte-poor, or monocytes or neutrophils, this is essential for ensuring patient safety. So high leukocyte counts, for example, may lead to excessive inflammation or increased adverse events. So when we talk about adverse events, we want systematic data collection that allows for identification and tracking of these adverse events or complications related to the orthobiologic treatments, including increased pain or swelling or decrease in function, so that we can make sure we are able to discuss this with our patients. When we talk about scientific advancement, we have this research and development, and delayed data collection supports this ongoing research and development efforts in the up and coming field of orthobiologics. Researchers can use this data to refine treatment protocols, develop new products, and enhance treatment outcomes. When we talk about publication and peer review, we'll go into this a little bit later, but collecting and sharing data with the scientific community through publications and presentations promotes this transparency and peer review, contributing to the advancement of the field as a whole. When we talk about customized treatment plans, looking at patient-specific data is really important, and collecting data on individual patient characteristics and responses helps clinicians to tailor orthobiologic treatments to the specific needs and preferences of each patient, as well as the specific diagnoses and patient-specific identification disease processes. This personalized approach can improve treatment outcomes. So continuous data collection allows for long-term monitoring of our patient's progress, and this enables us to adjust the treatment plans as needed. When we have data collection, many regulatory bodies require comprehensive data collection for orthobiologic treatments. This data is essential for obtaining and maintaining the regulatory landscape, approvals, and compliance with safety and efficacy standards within the orthobiologic treatment realm. When we talk about quality control and quality assurance, when we look at regularly assessing cellular content, this helps to maintain the quality and consistency of the orthobiologic products that you're producing. For injectate monitoring, it ensures that the product meets the predetermined or assumed specifications. And then finally, patient outcomes. Monitoring these patient-reported outcomes allows for practitioners to gauge the quality and effectiveness of the treatments that we're administering. This information can help lead to improvements in our clinical practice. And then finally, we can help engage our patients in informed and shared decision-making. When we use patient-reported outcomes such as pain, activity limitations, quality of life assessments, this involves patients in their own care. And this data helps patients and practitioners to make informed decisions about treatment options and adjustments, as well as expectations for treatment. So what data should we collect? So there is minimum reporting standards and the MEBO criteria. So when we talk about PRP, we talk about this checklist of items for study design, including whether the study was conducted in accordance with consort or randomized controlled trial, cohort, case control, cross-sectional, or meta-analysis guidelines. We then make sure and check institutional and ethical approval, demographics, including sex and age, comorbidities such as diabetes, blood dyscrasias, inflammatory conditions, pre-existing pathology and smoking status, current anti-inflammatory or antiplatelet medications, and injury details, the diagnosis, including relevant grading system, as well as the chronicity, results of any preoperative or pre-injectate imaging. Next is previous surgical or biologic treatments for this current injury intervention. We then have to list the intervention described sufficiently enough to enable replication. So this includes how much blood was drawn, how much was processed, how was it processed, what kind of centrifuge were you using, what kind of kit were you using, so that someone could follow along and reproduce or replicate this study specifically. And then we also need to define the intertreatment findings such as whole blood processing, storage environment, concentration and volume of the anticoagulant, temperature and light exposure, and the whole blood cellular characteristics. Additionally, and we want to talk about the whole blood platelet, the differential leukocyte count, the red cell analysis of all samples. We also want to describe the processing, whether the commercial kits were used in the SPIN protocols, the platelet recovery rate of the protocol, expected and or calculated, the PRP storage temperature and light exposure, and the time between the blood draw, the PRP processing, any activations, and the delivery characteristics. We also need to talk about PRP format, such as liquid, gel, or membrane, and then calculate or characterize the number of platelets, the differential leukocyte count, red cell analysis, as well as any activation needs to be described, including volume and concentration of the activating agent. And you then also need to describe the point of delivery. Was it intraoperative, postoperative, serial? Was it 1 a week for 3 weeks? And then the delivery itself needs to be described sufficiently to enable replication, including volume delivered, concomitant use of other items, details of carriers or scaffolds, and then the post-injection care. So a rehab protocol sufficiently described to enable replication, including immobilization, physical therapy, and then describe your outcomes assessments, including your functional outcomes, recording any complications, any infections, need for further treatments or surgery, any radiographic outcomes, physical exam finding outcomes, return to activity, satisfaction, radiographic outcomes, physical exam findings, and then return to activities and patient satisfaction. So there's also a cellular therapy MEBO study design checklist that is very similar to this PRP. I won't go over it in detail, and you can look this up, but basically what we talk about is that similar to the quality platelet-rich plasma concentrations and all of those things need to be sufficiently described and recorded so that if you desired, or if anyone desired, to be able to replicate your study, they could do so just going off of your data collection. So next we'll talk about a primer on cell counting. So cell counting is important because it provides our essential information about the cellular composition of the orthobiologic preparation, and it helps to tell us what the concentration of the different cell types, including white blood cells or leukocytes, platelets, and any other cell populations like monocytes. So, cell counting methods. Hemocytometer. This is a traditional manual method that includes counting cells using a special microscope slide called a hemocytometer. This method requires staining and careful observation, as well as a microscope. We also have automated cell counters, and these devices have an advanced technology that can automate, providing really accurate and efficient results. And we usually use them in clinical and research settings. So should everyone have an automatic hemocytometer? Well, you can be the deciding factor. There's a couple ways to decide. Talking about doing an manual count, either you can choose manual count, automated count, or you can send out samples. There are services that have sample send out calculations. So if you're doing this manually, you will need a hemocytometer report, a microscope, a hemocytometer chamber, a pipette and pipette tips, a centrifuge, obviously, to create the PRP with blood collection tubes, and a calculator. Remember, please also take your whole blood sample and count that. So the manual counting steps are: assemble the microscope, set up the microscope with the hemocytometer chamber, and ensure that it is clean and free of debris. Dilute your PRP sample, usually a 10-to-1 dilution. And to count, usually using the isotonic saline, you can use a 10-to-1 or 10-to-100, depending on your concentration. Load the hemocytometer chamber using a pipette. Load a small volume of the dilute PRP sample, and then make sure it fills the chamber evenly without overflowing. Next, count the platelets, and then place the loaded hemocytometer underneath the microscope and focus the grid lines, and continue to count several number of squares to get the average count. Or you can get an automatic hemocytometer, which seems to be quite a bit easier. The cost is about $25 per patient to know the starting and final dose of the injectate that you're using. So in looking at samples of an automatic cell counting, we look at the whole blood, the white blood cell count, platelet count, RBC, and then the lymphocyte, monocyte, and granulocyte counts. We then compare to PRP, looking at the white blood cell count, red blood cell count, platelet count, lymphocyte, monocyte, and granulocyte counts. So what is this business about leukocyte-rich and leukocyte-poor, and what about the monocytes? So to refresh, the cells of interest are leukocytes. These include white blood cells, including neutrophils, lymphocytes, and monocytes. And the specific types and proportions of the leukocytes can influence biological effects on the orthobiologic product. Additionally, monocytes are a type of white blood cell that can differentiate into macrophages in the tissue, which then play a crucial role in repair and immune response. So monocyte concentrations may be of significant orthobiologic interest when we're designing preparations for tissue regenerations. So when we talk about leukocyte-rich or leukocyte-poor, I think this is a little bit of an oversimplification, and it may not be that simple. So in leukocyte-rich, these preparations usually contain higher leukocyte count, including neutrophils and lymphocytes. The leukocyte-rich PRP may be used or recommended in specific situations where inflammatory response is desired, such as tissue healing in ligaments or tendons. The leukocyte-poor preparations have a reduced leukocyte concentration, primarily to minimize this inflammatory response, and are usually preferred in certain applications like osteoarthritis or intra-articular injections to avoid excessive inflammation that can sometimes be counterproductive. But we also have to account for the absolute count in which the leukocytes we are speaking of. As you recall, PRP is created with centrifugation to isolate the platelets based on density. And the leukocytes are also isolated by density, with the platelets being the least dense, and then the monocytes, and then the lymphocytes, and then the neutrophils at the bottom of the leukocyte count, and then the RBCs. So there are formulations that are monocyte-rich, neutrophil depleted, versus leukocyte-poor or leukocyte-depleted. So I think we have to be a little bit more specific, and that's why data collection and cellular data collection is really important. So a word on monocytes. Monocytes are a type of white blood cell that plays a crucial role in the body's immune response and tissue repair processes. And while platelet-rich plasma usually focuses on the regenerative potentials of the platelets and the growth factors, monocytes can indirectly influence PRP treatments in several ways, making them really important in the context of PRP therapy. So I wanted to share with you this comparative analysis of M1 and M2 macrophages from Dr. Pradeep Albert, MD. And he talks about that macrophages are essential immune cells, and they're classified into two major types based on their activation status and functional roles: the M1 macrophage and the M2 macrophage. And there's emerging research that emphasizes the significance of this polarization in diverse pathologies, such as like inflammatory diseases or cancer or autoimmune diseases. And he talks about the M1 macrophages being that classically activated macrophage that is stimulated by microbial products like lipopolysaccharides or cytokines, and they play a crucial role in host defense by producing pro-inflammatory cytokines like TNF-alpha, interleukin 1 beta, and IL-6, as well as reactive oxygen species. So to combat these invading pathogens. However, uncontrolled M1 macrophage activation can lead to tissue damage and chronic inflammatory conditions. Now, M2 macrophages are also known as the alternatively activated macrophages, are stimulated by IL-4 or IL-13. These macrophages play a role in wound healing, tissue repair, and immune regulation, producing anti-inflammatory cytokines like IL-10 and TGF-beta. They are characterized by their high production of scavenger, mannose, and galactose receptors, which aid in tissue remodeling and repair. So, in looking at PRP as an influencer of monocytes and macrophages, they do a couple of things. So the inflammatory response is mediated by the monocytes, which are part of the body's innate immune system and involved in the initial inflammatory response to injury or tissue damage. When PRP is injected into the damaged area, it can trigger a controlled inflammatory response where the monocytes are recruited to the site of injury or treatment and play a role in clearing the debris and initiating the healing process. So differentiation into macrophages. So when monocytes enter the tissues, they differentiate into the macrophages, and these are specialized immune cells with a wide host of functions, including phagocytosis, tissue remodeling, and immune regulation. And these are essential for tissue repair and regeneration. So macrophages are key players in tissue repair and remodeling. They help break down the damaged tissues and promote growth of new healthy tissue. So we also want to remember that immune modulation is part of the monocyte and differentiated forms of macrophages, they can help modulate this immune response, and they help balance the pro-inflammatory and anti-inflammatory processes, ensuring that the healing process is controlled and does not lead to excessive inflammation. Additionally, monocytes and macrophages also contribute to formation of new blood vessels, angiogenesis, in the area that's injured. And this angiogenesis is essential to delivering nutrients and oxygen to the regenerating tissues to facilitate repair and growth. And then the macrophages also release various cytokines such as growth factors like TGF-beta and VEGF. Now, these signaling molecules play a role in tissue regeneration and can enhance this regenerative potential of PRP. So while monocytes themselves are not primarily the focus of PRP therapy, their presence and function is quite important, and really, I think, requires a deeper look as to the growth factors and bioactive molecules that can activate monocytes, leading to a coordinated healing response that promotes tissue repair and regeneration. So I hope this has helped clarify why cell counting is critical to be able to define what we're actually using and what can actually affect the tissue where PRP is being used. And maybe we all should have the automatic hemocytometers to really enhance the field going forward and really clarify what we're actually using. So the next part of this discussion is regarding dose calculation. So once we know what the cellular makeup of our injectate is, then we can actually calculate the absolute platelet and white blood cell dose. So let's go through it. So we start with what, concentrate it to what times number of cc's equals dose. So the average platelet count in whole blood is 200,000 per ml. And then we calculate the concentration. Now there's this whole manual process if you'd like to do that, or you can rely on your automatic hemocytometer. Please remember that there is a conversion factor of microliters to milliliters. And so we have platelets per ml. And then when you compare this to your whole blood number, you can give an X factor. So concentrated to 10X times concentration. We then multiply this platelet per ml times the number of mLs that of your injectate, and you can get the total platelet dose in billion. So of note, 200,000 platelets per ml times 60 mLs blood draw gives you about 12 billion platelet dose, assuming 100% recovery of platelets. So let's go back and look at my example report of a real patient. So her whole blood, white blood cells is 5.1, platelet counts 176, which is a little low. That's not the 200,000 we were talking of. RBCs 4.3, lymphocytes 1.7, monocytes at 0.2, granulocytes 3.2. So we drew 120 mLs of blood and made some leukocyte-poor PRP and some leukocyte-rich PRP. And I think this is really helpful to be able to show the difference. So each 4 ml sample had 60 ml blood draw. So in the leukocyte-poor, the white blood cells count was 0.8, platelet count was 926, RBC was 0.05, lymphocytes 1.7, monocytes 0.2, and granulocytes 3.2. And so we had an X concentration increase of about 5.3 times concentration, and a platelet dose where you calculate, take the 926 times 4 mLs, gives us a 3848 or 3.5 billion dose for the 4 ml injection. Now, if we take the leukocyte-rich preparation, which is also from a 60 ml blood draw from her, the white blood cell count is 38.0, platelets are 2025, RBCs are 0.5, so limited contamination. Lymphocytes are 17.2, monocytes 2.9, and granulocytes are 17.9. Our X concentration increase was 11.5 X concentration, and our platelet dose is 8,100 or 8.1 billion for the 4 ml injectate. So looking at my patient specifically, if I had 100% recovery from my 60 ml blood draw, with her platelets being 179 times 60 mLs would be 10,500 or 10.5 billion in an ideal world. Now, obviously, our recovery was was not as high. And so some of that is because we were not, for that leukocyte-poor, we were leaving some of those platelets in the buffy coat with the white blood cells. And so when we are comparing leukocyte-rich to leukocyte-poor, we really have to be clear, is it a platelet dose issue, or is it actually the leukocytes? And it may not be clear based on how we get these injectates created. So hopefully that was some lovely, brilliant PRP math, and hopefully that helps clarify how to calculate our platelet dose. Lastly, let's just touch on patient-reported outcomes from the registry data. So data reporting is really important. Cell counts are reported in this cells per microliter, and then we really have to translate that to cells per ml to get the proper dose and the intended application. So just really be clear on this idea that we really have to be clear on platelet dose. Additionally, if you are not currently calculating your platelet dose, there is a way for you to send out a certain number of samples for quality control. And it's essential to maintain quality control when you're performing this cell counting to ensure accurate and reproducible results. So we want to make sure that what you're producing, at least from a concentration standpoint, is what you think you're producing. But honestly, I think it's probably better, because it's so variable and we really need help to drive the field forward, that we would like to have that data on every single patient who's getting these orthobiologic injections. Additionally, interpreting results. So interpretation of the cell counts in orthobiologics depends on the intended use and what your desirable injectate may be. Lower counts for joint injections, where you wanted elevated counts for tendon or ligament applications. So, as in review of what we've kind of covered, which is quite a lot, data is how we know and how we make decisions going forward for our patients. We've talked about the MEBO criteria in which data we should be collecting, given you a bit of a primer on cell counting. I've weighed in on whether an automatic hemocytometer would be helpful. We've talked about leukocyte-rich, leukocyte-poor, and monocyte, and maybe it's not as clear as just straight leukocyte-rich or leukocyte-poor. We've given some PRP math for dose calculation, and we've talked about some patient-reported outcomes and registry data. So why do we collect data? So we can customize treatments for our patients based on scientific evaluation, so that we can advance this amazing field, as well as quality control, safety, and monitoring for our patients. So in the words of Jeffrey Moore, without data, you are blind and deaf and in the middle of a freeway. So thanks so much for listening, and stay tuned for our next discussion on patient education and informed consent. This has been the Business of Orthobiologics podcast. Thank you so much for joining us today. If you want to know more, please join us on the website prp-now.com and click on the free masterclass. Also, don't forget to subscribe to this podcast to get more guidance on integrating PRP in your busy practice. Bye for now.